Good evening, friends. We warmly welcome you for this edition of the PG Clinics. We have very eminent teachers today. We have Professor Ramya ma'am from Sri Ramchandra Medical College, Chennai. We have Aparna ma'am joining from KEM, Mumbai. I guess Madhu sir has still not finished his surgery. So he is expected to join probably a little late. So we also welcome our senior faculty members of the committee, Professor Kanna sir, Andarya sir, Srinivasan sir, Rajiv Sahay sir. So friends, today we have two important exam cases. One is an obstructive jaundice, the other one is a gastric outlet obstruction. So obstructive jaundice is kindly contributed by Professor Naveen Alexander from Sri Ramchandra Medical College. And the other candidate, Dr. Asha, is from Professor Khanna sir's department, where she is under Seema ma'am's unit. So she is going to present a case on gastric outlet obstruction. So Dr. Asha will go first. Dr. Asha, please share your PowerPoint. She will introduce her unit chief, introduce herself, unit chief, and then head of the department and start the presentation. Over to you, Dr. Asha. Faculty, please take over. Asha, can you share the PPT?
Yes, sir. Yes, sir.
Good luck to you, ma'am. Make it full screen.
Yes. Are my slides visible?
Yes, ma'am, you're good to go. Good luck.
Yes.
Yes.
Good evening, sir. Thank you, PG Clinics. Sir, I'm going to present a case from IMS BHU, sir, my college, and my moderator is Professor Ajay Khanna, sir, and my thesis guide is Professor Seema Khanna, ma'am, and head of the department, Professor Seema Khanna, ma'am, from IMS BHU, Varanasi, sir. Shall I start my case?
Yes, madam. Yes, madam.
So, a 55-year gentleman, farmer by occupation, resident of Aurangabad, Bihar, belonging to low socioeconomic status, presented with vomitings from past 2 months and pain abdomen for past 1 month. Vomitings were sudden in onset and progressive. Initially, he had 1 episode per day and later currently progressed to vomitings after every meal. It occurs usually 30 minutes to 1 hour after food intake, containing partially digested food particles around 200 to 300 ml in amount, which were non-projectile, non-bilious, not containing any blood and non-foul smelling.
Bit slow, ma.
Yes, sir. Pain in the upper abdomen was for the past 1 month, which is of insidious onset and gradually progressive. It was dull aching in nature, mild to moderate intensity. It was not radiating, aggravated on food intake and partially relieved after vomiting, sir. There was a history of bowel rolling movements in the abdomen from left to right after food intake. And there was a loss of appetite, loss of weight, which was not measured by the patient, but was noticed as loosening of clothes. Also, there is associated postprandial fullness and early satiety of new onset, sir, for the past 1 month, and a history of easy fatigability and constipation. There is no history of hematemesis or melena. There is no history of jaundice. There is no history of cough, chest pain, or hemoptysis or breathlessness. There is no history of bony pain or headache. There is, in past history, there is no history of any peptic ulcer disease in the past. There is no history of chronic drug intake or corrosive intake. There is no history of any surgical intervention in the past, and there are no known comorbidities. And there were no similar complaints in the family, and also there was no history of any malignancy running in the family. So, coming to the personal history, he used to consume normal mixed diet in the past, but for the past 2 months, he is on liquid diet. He is known smoker, smokes 1 pack BD per day for the past 10 years, which comes to 10 pack years. He is non-alcoholic. His sleep pattern is normal. Bladder habits are normal, but has constipation as mentioned earlier. Summarizing my history, he is a 55-year gentleman smoker presented with a recurrent non-bilious vomitings, which occurs 30 minutes to 1 hour after food intake, containing partially digested food particles for past 2 months, along with dull aching pain in the upper abdomen for past 1 month. There is associated loss of appetite, loss of weight, early satiety, postprandial fullness, and easy fatigability for the past 1 month.
Yeah, Dr.
Sir.
What do you think you're giving us?
Sir, my history is consistent with sir gastric outlet obstruction, sir. Likely of my. Sir?
Is it working?
Sir?
What will be the cause of gastric ulcer?
There's some disturbance in your mic.
Rajinder, I think there is some mechanical sound which is coming from your side. Probably the mic or something is not okay, I guess.
Sir was asking, what is your probable? Why do you say it's gastric
Yes.
outlet obstruction?
Sir, because the vomiting is non-bilious, sir, and it is 30 minutes to 1 hour after the food intake, and the vomitus is containing the meal which he consumed just 1 hour before, sir. So likely it is gastric outlet obstruction, sir. And I suppose it may be due to some malignant etiology, sir, because the elderly male and smoker and low socioeconomic status, and also there is a short duration of history for only 2 months, sir, and associated loss of appetite and loss of weight and early satiety postprandial fullness. So I think it is
Dr. Asha,
No,
would
what is
recommend-
it? You're telling too many
Madam,
symptoms.
1 minute, man, 1 minute.
Yeah, sorry,
Asha,
sir.
you have to talk slow, right?
A
So
bit
this
fast.
is a
Sorry,
big
sir.
forum.
Just-
Don't rush through. So you talk slow.
Sure,
Any
sir.
answer, you please internalize the question, then start answering. You
Sure,
go
sir.
on a slow pace. You
Okay,
go
sir.
50% slow on what you are talking. That will make things much easier.
Sure,
And I
sir.
also warmly welcome Professor Aparna ma'am. Madam, thank you for joining. Madam is Professor of Surgery from KEM Hospital and St. J.S. Medical College, Mumbai. Welcome, ma'am.
Thank you, Dr. Kandagavel. I'm sorry, there's some technical issue with connecting, so I
Ma'am,
just...
perfectly understood, ma'am. Perfectly. We just started, ma'am. Please join, ma'am. Ramya, ma'am, please take over. Sorry for interrupting.
No worries. I also wanted her to requested her to speak a little more slowly
Sure, ma'am. Sure, ma'am.
to all the other postgraduates listening. We
Okay.
Sure,
can
ma'am.
the speed, but it should
Gastric
benefit the
outlet.
audience for whom it is meant. Okay.
Yeah.
So my question is,
Go to the first slide.
say it's an outlet obstruction. Where is the outlet of the stomach?
Ma'am, pylorus, ma'am.
So what is the normal gastric emptying time?
3 to 4 hours, ma'am.
So you're saying vomiting after 30 minutes. You think the food has reached the outlet?
Ma'am,
What is the emptying time for solids? What's the emptying time for liquids?
yes, ma'am. In a for solids, it is 3 to 4 hours, ma'am. For liquids, it's 1 to 2 hours, ma'am.
So I don't think you can really categorize it as an outlet obstruction. If you strictly go by the timing, it could be in the body of the stomach also.
Yes, ma'am.
Doesn't mean just because it is non-bilious, it's always at the outlet. It could be in the body, right?
Yes, yes, ma'am.
So the timing of the vomitus is very, very important. You're saying it's not foul smelling, 1
Yes,
hour after eating food. Obviously, it will be partially digested only. So
Yes,
it cannot equal or amount to G over from the history.
Yes, ma'am. Patient is also on the liquid diets only, ma'am, for past.
That doesn't really matter at all. That is his choice. He's decided
Yes.
to take liquid because maybe he's able to tolerate liquids
Only
better
liquids.
than solid. That is totally different.
Yes, ma'am.
Okay. The second question is, what do you mean by satiety? When will the patient get early satiety? If there is early satiety, what is the inference?
Yes, ma'am. Satiety is a feeling of complete feeling of completeness of the stomach, ma'am. Fullness of the stomach, like it's feeling of
Literal meaning is they feel
satisfied with the
contented,
hunger.
satisfied. That means the stomach is full. Basically, that's
Yes,
what
ma'am.
it means.
Yes,
Okay. So early satiety, when will the patients exhibit? What kind of pathology will you have early satiety?
Ma'am, when the distensibility of the stomach is affected, ma'am. In cases where
Correct. Very correct. Tell me causes for reduced distensibility of the stomach.
ma'am, in cases of carcinoma stomach, where the linitis plastica type of diffuse type of cancers, ma'am, where the distensibility is affected.
Correct. Any other reason, ma?
Even
Something extraneous compression that prevents the stomach
Yes.
distending, isn't it? It could
yes,
be,
ma'am, like
as you rightly said.
PPs,
Madam, can I add
Pseudocyst.
one thing?
pseudocyst
please,
of
please, sir,
pancreas.
please.
Dr. Asha, see, gastric
Yes.
outlet obstruction and early satiety usually do not go together.
Absolutely, sir.
Right?
Absolutely.
So at one moment, you are thinking of decreased capacity of stomach, and the outlet obstruction leads to distension of stomach. The patient may have vomiting, which patient has taken the meal in the early phase, maybe even up to 24 hours earlier, he may vomit because the stomach is hugely distented, right? So this
Yes, sir.
do not go together. Okay, madam, carry on.
Yeah, thank you, sir. I wanted to say the same thing, that early satiety and outlet obstruction, distension doesn't go hand in hand. Okay.
Yes, ma'am.
So be very careful in your choice of words, and you should mean what you're telling exactly. So two things opposite, contradicting, and you cannot say this is GOO. Okay, I'm just trying to correct you on that.
Yes,
Right? Can you just go to the next slide?
I just want to ask Dr. Asha,
Sure.
yes, sir.
in which kind of, what condition will you have vomiting so early, 30 minutes?
If it is a proximal obstruction, sir,
What kind of proximal obstruction?
in cases of GE junction obstruction, sir, where
Right, esophageal
esophageal.
problem, right?
Yes, sir.
So this history of yours is not commensurating with, is not equating with it with gastric outlet obstruction. Early satiety, early vomiting. You said it's foul smelling. There's no foul smell. Why would you think they would? Why did you ask for this?
Sir, if it is long-standing, then the foul smelling it can be there, sir. And also, if it
Why
is
does that foul smell happen?
due to the stasis and bacterial growth, sir, there is foul smelling of the. Maybe, sir, in cases like achalasia also, where there is long standing of food, or in Jenkers, whether there is long standing of food, there is foul smelling, sir. In gastric cases, because of the acid, usually it will not promote the bacterial growth. So likewise, I can differentiate it from esophageal and gastrics.
Look, in gastric outlet obstruction, two things are very important there. Your history should be very, very complete. That is vomiting and pain, because these are the
Yes, sir.
only two symptoms which are going to distinguish from other conditions,
Yes, sir.
right?
Yes, sir.
So, and usually we expect in gastric outlet obstruction to be foul smelling, because all of it doesn't come out. The stomach is so distended, it cannot contract and chuck out everything.
Yes.
Right? So some food particle will always be left behind, and whatever comes out is foul smelling.
Yes. Okay.
Right. Also, you must ask the patient, did you ask whether the vomiter stains the floor or not? Why is that important?
Bile, if it is present, it will stain.
Does the vomiter stain the floor or not?
Normally, it won't, sir.
Why?
If it is only gastric acid secretions, yeah, or food particles, it won't. But if it is bile, then it will, yes, it will stain.
Acid will not stain and bile will. Is that what you mean?
Oh, sir, floor. Okay, sir. Now I get it.
So in which condition would you find the gastric vomiters not staining the floor? When there is?
I'm not sure, sir.
When there's achlorhydria.
Okay, sir.
And in which condition would you find achlorhydria?
Pernicious.
No, not pernicious.
No, in this scenario, elderly
in
person.
this scenario.
Ma'am, in carcinoma stomach, sir, when there is
malignancy. Malignancy is visually associated with achlorhydria.
Achlorhydria.
Right. So your history is not complete as such, right? Okay. About pain, let's go to the pain. Ma'am, please take over, please, ma'am.
Yeah, no worries, sir. You did say that. So when do you expect this kind of pain to radiate? You said non-radiating, right?
Yes, ma'am.
So you expect some radiation to occur. When will it occur?
Ma'am, if it is ulceration, ma'am, then the pain will radiate to back, ma'am. Or if it is a growth, then it may not radiate.
No. Okay.
No. The other way around, you're saying. Okay, see stomach with infiltration into the pancreas, you may have pain.
Pancreas also, it may
okay,
radiating to
rarely
back.
A benign ulcer infiltrating the sitting in the posterior wall of the stomach. There, isn't it? So it is more of a malignancy that you should worry about. Is it infiltrating the pancreas when they have a pain radiating to the back? So every question you ask, there is a significance. Every answer the patient gives, you should be able to interpret accordingly. It is not that You have to ask 10 questions, you ask all the questions. Okay.
Yes.
So here the radiation is all the more important because that will give you a clue
Filtration to
whether
the
this is
adjacent
infiltrating
organs.
the pancreas. You don't really need a CT scan to tell you that. From the history, you can make that out very easily, isn't it?
Yes, ma'am.
Yeah. Go on.
So Asha, there can be direct infiltration or it can be involvement of the lymph nodes,
Yes, sir. Compression.
right?
Yes.
Which can press onto the compression onto the celiac axis,
Yes.
celiac plexus. So all these this is basically malignancy.
Yes, sir.
Benign conditions usually don't, right?
Yes.
Correct. Yeah. Go on. Next.
Why is the pain aggravated by food intake?
Yeah.
So maybe due to the stretch of the stomach, sir. Because of stretching, there is
So
pain.
you think stretching of the stomach, you can have, you belong to Banaras. There are pandas there who can eat pails and pails of food. Does stretching of stomach lead to pain?
If there is loss of distensibility due to infiltration, sir, then the stretch can cause.
It will
The
not
stomach
stretch. No, it will not stretch then.
Stomach as such doesn't cause pain on stretching, right? The pain is only because of infiltration, involvement
Yes.
of the neurovascular system, right?
Yes.
Okay. Weight loss, history of ball rolling movement. What do you mean by this ball rolling movement?
Patient notice the moment of something moving on his abdomen from left to right when he's taking fluids, sir.
Okay. So when does this ball rolling happen? How is it related to? Is there a relationship to any other symptoms? This ball rolling. When does it happen?
So after consumption, after 30 minutes after consumption, ball rolling movements will start, and this relieves after vomiting.
Right. So it usually happens before vomiting.
Yes.
That is the thing. You should say history of ball rolling movement of the in the abdomen before vomiting, or followed by vomiting immediately. So
Yes.
why does this ball rolling happen? You tell me. You not tell me. Why does it happen?
So it's due to the contraction of
What's the pathophysiology behind it?
contraction of the stomach against the obstructions due to the due to
Right.
the
Right. So in which direction would it go from?
left to right, sir.
Suppose it's going from right to left, then
So it is of intestinal, probably colonic, transverse colon, moves from right to left.
which column? Yeah.
Transverse colon.
Okay. So now, if the patient, what are the causes of gastric outlet obstruction? Because he's written loss of appetite. So benign condition, he doesn't have any past history of peptic ulcer disease, isn't it?
No, sir. No, sir.
So how do you relate this loss of appetite now? What does it tell you about?
So,
Whether the condition is benign or malignant?
sir, I think it is towards malignant etiology, sir.
Right. Okay. So next time, then you said there's no history of hematemesis or melena
Yes, sir.
and no coffee ground.
No, sir. No
Vomitus.
coffee ground vomiters.
I think you should mention that there's no coffee ground. So in malignancy, which kind of malignancy will you get this gastric outlet obstruction without melena, without hematemesis?
So if it is Linitis plastica type of diffuse variety.
Look, Linitis plastica will not give you this kind of vomiting. The stomach can hardly contract.
Yes, sir.
So Linitis plastica will not give you this kind of vomiting with which is like gastric outlet obstruction.
Yes, sir.
So what kind of malignancy, what condition will you think of now? No hematemesis, melena, yet the patient is having vomiting, symptoms of gastric outlet obstruction, and is probably malignant.
Localized variety, sir, of Linitis. It can.
Linitis plastica, localized variety. Just carrying it a bit too far.
Infiltrative type of, sir, diffuse type, where diffuse
Something
variety.
pressing it from outside or within the wall.
Yeah, we
mucosa
discussed
is
that in the
intact.
beginning, no? Anything from outside.
Lymph node compression from outside, sir, at the
Right, or any
outlet
tumor
obstruction.
which is in the wall and the mucosa is intact,
Yes.
isn't it?
Yes.
Right. Okay. Next slide, please.
Yeah.
Ma'am, please.
Yeah, no problem. Sir. Go to the past history, ma. So, sir had already discussed that no history of peptic ulcer disease. So, what is a surgical intervention in the past that is of significance that you should ask?
Ma'am, if he was operated for peptic ulcer in the past, like truncal vagotomy and
Asha, how many truncal
What?
vagotomies have you seen in your
I didn't-
has happened in the last 10 years, hospital in 10 years?
I didn't.
Why truncal vagotomy?
Um,
It's gone, over,
Yes.
finito. We don't do it anymore.
okay, sir.
We do it when we are residents.
Sir, in case of Billroth 2 surgery, sir, where the stump carcinoma can happen again, sir, and it can cause again.
Yeah, like the sir said, it is now almost, we hardly do any TVGJ and 20, 30 years back. So this gentleman is now what, 66 years old. How old is he?
55, ma'am.
55. So unlikely you would have had it, but suppose a patient is around 70s, still there is a possibility as a youngster in his early 20s, he would have had a TVGJ or an antrectomy with a gastrojejunostomy, the Billroth type 2, as you very rightly said. So why do they get the stomach cancer in these patients, in the remnant of the stomach as it is called? What is the cause?
Yeah.
Ma'am, as
What is
the
it that you are
acid secretion.
anastomosing? What is it that you're anastomosing? No, acid secretion. You remove the acid secreting part of the stomach.
Part
The
of the stomach.
anatomy is done and a GJ is done. There is no longer acid secretion. So what is the culprit this time?
Reflux, ma'am.
Of
Reflux of
what?
what?
Bile reflux, ma'am.
Huh?
Irritative, which irritates the
Bile
mucosa.
reflex, it causes bile gastritis. Bile gastritis
Gastritis.
will lead to metaplasia and to dysplasia and to carcinoma. Not metaplasia, dysplasia and carcinoma. So basically, it is the bile that irritates the stomach because there is some amount of bile refluxing into the stomach. So that is why this history becomes important. That could lead to a carcinoma in the remnant of the stomach. So with that in context, maybe not for people who are 50 years, 40 years old, but older people, definitely this has got a significance, isn't it?
Yes, ma'am.
Okay. Yeah, please go on.
Okay, we'll ask you later what is to be done to prevent that. You said corrosive intake. What corrosive intake would be causing cancer?
Sir, alkali injections are in the past corrosive, which
What's the difference between ingestion of alkali and ingestion of acid?
sir, when alkali is and when acid is ingested, sir, it immediately corrodes, but the later it doesn't penetrate deeper, sir. The effect, but in alkali it penetrates deeper.
What kind of necrosis or necrosis is happening in acid?
Coagulative necrosis, sir.
Right.
When
And in
alkali, so liquefactive type of.
So if it is coagulative, what happens?
The mucosa, the protein is coagulated, sir, and so the barrier is.
So there's an ishar which is informed, isn't it?
Yes, sir.
There's a layer which forms, and that protects it from further damage.
Yes, sir.
Right. So what kind of do you think corrosive would an alkali cause a gastric outlet obstruction or an acid?
Sir,
you know what is yo-yo damage?
After a time, it continues the damage, sir. Like in alkali.
Oh, in acid, what happens? It goes into the stomach. The stomach contracts, and it sends it back to the esophagus, and it comes back again. Keeps going up and down. Right.
Okay.
Well, in alkali, doesn't happen. Okay, let's go to the next slide.
Okay, go on. Yeah. So next is a summary slide, I think. Anything else?
Okay, Dr. Asha, a bit of history. Can you tell me a family which was affected by gastric carcinoma. Very famous family in Europe.
I'm not sure. I'm not known.
Not heard of him? Napoleon?
Alexander.
Napoleon Bonaparte.
Napoleon Bonaparte.
Right. His brother, father, the whole family was affected with malignancy. He also died of gastric malignancy. Right. Okay. Next slide. Go on, please.
Yeah, go on.
Ma'am.
Yeah. Okay, so now would you like to re-summarize or you still want to stick to your same summary?
I would avoid the early satiety things.
Okay. And you're vomiting?
1 to 2 hours after food.
Light. Okay. I'll tell you, Dr. Asha, it's best, what happens that when you take the history and examination and you come to a diagnosis, then you should go back to your history and see whether your history fits in with your diagnosis. Right?
Yes.
But if it doesn't, then you should try and take the history again because there's something missing. There could be, right? So that's a good way of presenting history. You take a history, you take examination, come to a diagnosis, then go back and see whether your history is fitting into your diagnosis.
Yes.
Right? Okay.
Yeah, okay.
Can I ask a question?
Please, ma'am, please.
Yeah, so I came in a little late, so I don't know whether this was discussed, but Dr. Asha, can you describe a classical history of a gastric outlet obstruction patient? Was it discussed earlier already?
It's okay, ma'am. It is good to reiterate this important point. Just discussed it, but she can tell us now.
Okay.
Ma'am.
She's a pundit on it now.
So now she knows the answer. So she can. Okay.
Yeah.
Yes.
Ma'am, patient have the vomitus is usually 1 to 2 hours for a liquid food, 3 to 4 hours for a solid food after the food intake, which is usually foul smelling and containing partially digested food particles, which is non-bilious, non-projectile, and hello, ma'am.
Yeah. No, I think there's some disturbance in some line.
Yes, ma'am. Associated.
Okay. Anything else? See, the classical interval for a gastric outlet obstruction, vomiting, is not 1 or 2 hours or 4 hours.
It's a gastric before the gastric emptying time.
No, what is the
No, much later than that. Much later.
The patient will tell you that today I vomited the food that I ate yesterday or day before yesterday. So I'm asking you for a classical gastric outlet, which we are considering here that we are going towards malignancy. I'm asking you a classical gastric outlet obstruction. What is the type of, what is the history that the patient comes to you?
Foul smelling, vomiting, ma'am.
Okay. Okay, go ahead.
Coming to the general physical examination, patient is conscious, oriented to time, place, and person, vitally stable, temperature is afebrile, pulse rate is 64 beats per minute, which is normal in rhythm and volume, regular in rhythm, normal in volume. Blood pressure is 110 by 70 millimeters of mercury, measured in the right arm in supine position. Respiratory rate is 16 per minute, thoracoabdominal. Hydration is adequate. There is no pallor, icterus, cyanosis, clubbing, pedal edema, or generalized lymphadenopathy. There was no palpable left supraclavicular lymph node or axillary node. His performance status was good, ECOG 1, moderately built and moderately nourished with a BMI of 20.2 kilogram per meter square, and his back and spine examination were within normal limits. Coming to the periabdominal examination, on inspection, fullness is noted in the epigastric region, which is extending in the umbilical and hypogastric regions, and also into the both lumbar regions. And umbilicus is central and inverted. All quadrants were moving proportionally with respiration. And on food ingestion, visible gastric peristalsis were noted from left to right. There were no other, there were no scars, there were no nodes or scars or pigmentation or dilated veins noted. This is from the lateral side. Hernial sites were intact and external genitalia were normal. On palpation, the abdomen was soft and there was a vague, ill-defined lump. Sir?
Yeah, you please continue.
On palpation, abdomen was soft. A vague, ill-defined lump was noted when patient was orally allowed, which is the same as described from epigastrium to umbilical and hypogastric and bilateral lumbar regions, which is has smooth surface, soft in consistency, and there is no tenderness, and there is no local rise of temperature or tenderness, no palpable lump underlying, and there is no organomegaly. Hernial orifices were intact. On percussion, the liver span was 14 centimeter. Upper border of liver was noted at the 5th intercostal space along the right midclavicular line. Impaired resonance was felt over the fullness, and there is no free fluid in the abdomen. On auscultation, normal bowel sounds were heard, and the succussion splash was present.
What other palpable lumps were you looking for? You said that there was a palpable lump.
There were no
Then
palpable.
yeah, so there is already a palpable lump in your first line.
Ma'am,
You go back 2 slides.
There was a fullness and lump noted,
Yeah.
ma'am, only when
Your
the patient was
vague-
oral. Yes, ma'am.
Vague ill-defined lump is noted.
Yes, ma'am. Only when the patient was orally allowed, it was prominent, ma'am. In a resting state, it was not well appreciated, ma'am. It was just like a fullness, ma'am. So I was considering it to be a dilated stomach rather than a lump, ma'am. And I did a deep palpation to look for any other palpable lump, but there was no any palpable lump underlying. Ma'am, on all auscultar percussion, ma'am, the stomach appears to be dilated below the level of umbilicus, ma'am. And parietal examination was normal. There were no pelvic deposits, and there was no supraclavicular lymph node enlargement. Other systemic examination were also within normal limits, ma'am. Summarizing my case, as a 55-year gentleman smoker presented with recurrent non-bilious vomitings, 30 minutes to 1 hour after food intake, containing partially digested food particle for past 2 months, along with dull aching pain in the upper abdomen for 1 month. There is associated loss of appetite, loss of weight for past 1 month. On examination, when patient was orally allowed, a vague ill-defined lump was noted in the epigastrium, umbilical, extending into bilateral lumbar, iliac, and hypogastrium, with a smooth surface, ill-defined margins, and soft consistency, and visible gastric peristalsis was seen. Succussion splash was present, and on auscultoscopy, the greater curvature of stomach was marked below the level of umbilicus.
Again, your history is somehow not commensurate with the picture that you're showing, the picture of the patient that we are seeing on the screen. But I don't know why that should be so. So can we ask her the diagnosis?
I think first
yes,
we'll discuss the findings, ma'am.
Okay, yeah.
Discuss the findings, because
Oh,
I think
right.
what you have described as a vague lump and all that, all you have to say is this visible gastric peristalsis.
Yes, ma'am.
Enlarged
Okay.
stomach with a.
Yeah, you can say it's a dilated
And
stomach with a
dilated
VGP
stomach,
seen. Yeah.
with a VGP.
Yeah, that's it you have to say. Don't describe it as a lump. That's why we're asking which other lump you're looking for.
No,
What-
ma'am, it was not like a lump.
Basic-
It was like a ill-defined vague.
No, don't
Dilated stomach.
say lump. You just say clear cut.
Just
You're
say it's a
good guy.
dilated
You
stomach,
know what
nothing
it
else.
is.
It was a dilated stomach.
With the VGP. That's it
Yes,
you have
ma'am.
to say.
Yes.
So why you try to palpate a lump? Where you try to palpate a lump? You think you'll expect a lump in this guy?
But
Where is the stomach border, you said?
ma'am,
You said no, greater curvature?
yes, ma'am. Like it was like this.
Yeah, you showed the picture. It's very,
Yes, ma'am.
isn't it?
Yes.
So what is a lump that you're worried about? Like ma'am asked, no, what lump you're trying to palpate?
If I can palpate any, because in history, ma'am, I was thinking of a malignant etiology. So I thought I was in palpation. I was thinking for
Yeah.
any lump.
Dr. Rajiv Sahai sir already has told you. So this is something very important for you to remember, that you have the history of the patient, then you have examined the patient, and then you should go back and try to see what is it in the history that is not matching, and then come with a complete. So if you are looking at history in isolation and in examination in isolation, that is where the problems start. When you're appearing for MS, we expect that you have the entire information, and then you will go back and review your history.
Yes, ma'am.
Okay, so I think that is where you are thinking in terms of one diagnosis. So you're trying to fit everything into that. But when you have a
Correct.
finding, when you have a very certain finding, you have to now actually go back and see what is it in the history that probably has not been retrieved from the patient, or the patient has not been able to tell you properly.
Even the shape which you have shown probably does not match
Yeah.
with distended stomach.
Yeah.
Second thing, probably you know the CT scan findings, right? Am I right?
Not when I saw the patient, sir. Patient.
No. When you took history, at that time did you know that he has some?
No, sir. I took the patient in OPD.
Okay. Can it be a chronic disease? Hugely distended stomach, almost going up to the hypogastric region.
Yes, sir. It can be a chronic etiology. So I asked him
this is what you
for the
should have
chronic.
thought of.
A chronic chronic peptic ulcer, chronic duodenal ulcer.
Whatever, chronic gastric outlet
Some
obstruction.
chronic
Then
conditions.
then you can go for the further discussion depending upon the history.
Yes.
So there's no need to look for a lump. You're not now. It's
Okay.
not stomach. You had thought it was CA stomach in your mind, with the history of loss of weight, loss of appetite, all those things. Okay, agreed. But like ma'am says, go back now. The finding is not consistent with the CA stomach. CA stomach, the stomach will lose its distensibility, isn't it? That's why they have a vomiting, everything. It'll never come like this. Absolutely not. Okay.
Yes, ma'am.
So you have to go and alter. So no need to worry about the lump. You should just worry about the VGP, the succussion splash, everything. So it looks like a benign etiology now because, like sir said, go back and review.
Grossly distended stomach.
Yes, you'll never get it in a malignancy.
Dr. Asha, let's go back to your first slide of examination. First, before that, general examination.
Yes.
Right. You said the hydration is adequate for.
So there were no signs of dehydration, sir.
You think that was possible in a patient who has been vomiting?
No, sir. That's why I assessed her by seeing the tongues or whether it's moist.
You said you saw him in the OPD.
Sir?
You saw this patient in the OPD. You saw this patient in the OPD.
Yes, sir. He came in the OPD basis, sir.
So you think he would be hydrated when he came to the OPD? He's been vomiting. He doesn't retain anything.
Yes, sir.
So I think it's. I wouldn't accept that. Okay. Right. Okay. Now you said just go to your next slide. You said there's VGP. What do you mean by VGP?
So
Where do you
visible.
know VGP in this patient in this dilated stomach?
So I saw it from here to here, sir. From the left upper quadrant to the right lower quadrant. So it was moving.
How does it move usually?
So it moves from left to right in like this, sir.
Right.
Usually. But here it is moving like this, sir.
In such a dilated stomach, usually VGP will not be demonstrable. Right.
This was the photo I took.
You said, okay, just go back to your next, go to your next slide. Next. Okay, you said after how long, how do you examine for VGP? What do you do? You said there is succussion splash, is it?
Yes, sir.
Okay, so how do you look for succussion splash?
So actually, initially, first I looked for succussion splash, sir. Because I'm seeing the fullness. I went in this way, sir. I saw the.
How do you do?
What is the basic criteria you have to do before you demonstrate it?
So the patient should not been taken any fluid or food for the past 4 hours, or at least.
Okay, 2 hours. 2 hours.
2 hours.
Fluids, liquids for 2 hours. Okay.
Yes.
Then how much liquid do you give him?
So for VGP, sir.
Succussion splash.
In this case, I didn't give any fluid for succussion splash. It was very well demonstrated.
So he was nil oral for. Was he nil oral for 2 hours?
Yes, sir.
Okay.
No, but then in your presentation, you said allowed orally only, you saw the VGP, right? You said that. Repeat.
Yes, ma'am. First,
right,
I saw the patient, sir, ma'am, on inspection, and then I went for succussion splash, and then I gave him fluids, and then when I saw the VGP, then I took the.
How much fluid did you give him?
So he was not tolerating much. He took 1.5 glasses of water, sir. Around,
how much would that be?
So around 400 ml.
Come on, you give 400, he's not tolerating, or you say not tolerating. What do you want to give him? A pail of liquid fluid or something?
Yes.
So 300 ml is sufficient to demonstrate VGP. Okay.
Okay, sir.
Now, where do you see the VGP from? Which is the best way of visualizing VGP?
I didn't get it, sir. On inspection.
On
At
inspection.
what is the position of the patient? Where should you stand?
And where are you standing?
Laterally, sir.
No, it's best seen from the foot end. Okay. Okay. Suppose you give in water and you can't demonstrate VGP, right? So
Yes.
what can you do to stimulate that VGP? What can you do?
So
Do you know the answer? If you don't, I'll tell you.
I'm not sure, sir.
Yeah, you should say, I don't know, and I'll give you the answer. Right? You got to rub the abdominal wall vigorously, right? Or pour some ether. This will be done previously, just to pour some ether, and then it used to happen. So, okay. What was your the tone? It was what was the it was on percussion. What was the tone? What was the
Sir,
note?
it was a resonant, sir, but it's a impaired note, sir. It was
Is it resonant or is it tympanic?
resonant, sir.
Okay, when will you get a resonant note and when will you get a tympanic note?
So
Will the stomach contain completely fluid, or does it contain air and water?
air and water, sir.
So you should get a tympanic.
Tympanic, sir, but in this,
If it is
maybe I,
completely full of water, then you get a resonant note.
Mm.
Okay. Now, what was how did the stomach feel like? What was the consistency of the stomach?
so it was soft, sir.
Okay, it's soft, boggy, right?
Boggy.
Because of why should it be boggy?
Because of the distended stomach and containing.
Because of inflammation, chronic inflammation, right? Okay. Right. Okay. Next, ma'am, please.
Yeah, no problem. Okay. So you're still behind the supraclavicular lymphadenopathy because we're still trying to rule out malignancy, isn't it? That's okay. Completion, you have. Why left supraclavicular?
Ma'am, as the abdominal organs are drained by thoracic duct, which drains at the junction of internal jugular and the subclavian, and that time there can be a reflex, and the first node which receives it will be the left supraclavicular lymph node. So we usually see that in suspected cases of intra-abdominal malignancies.
Okay, fair enough. Right. Okay, so any other slide and your diagnosis now? You want to change it? You want to stick to your original diagnosis? How is it?
Ma'am, I would like to stick with the gastric outlet obstruction due to a malignant cause from the distal stomach, ma'am. That is malignant distal CA stomach with a differential diagnosis of chronic peptic ulcer. Malignant, I would like to stick to malignancy, ma'am, because the elderly age and a short duration history and associated loss of appetite, loss of weight. So I would like to stick with the malignant etiology, ma'am. It can be benign etiology also, ma'am.
What is the WHO classification of elderly now?
Sorry, ma'am.
It is no longer 55 is actually the 60 is the middle age.
Middle age, ma'am.
Yeah,
60,
70 plus is elderly.
elderly.
So 55 is young actually. Okay, CA stomach can occur in young people also, I agree, but don't say elderly male.
Sure.
Examiners will get hurt.
So that's why scientific evidence, I'm saying WHO classification. Okay. Okay.
Old age is 85.
But Dr. Asha, what is the survival in an untreated carcinoma stomach? Average survival.
I'm not sure, ma'am. Maybe some 3 years.
Yeah. How long do you think the stomach is being dilating to reach this size from the below the rib cage normally to all the way to the pelvis?
Maybe a
He has
year.
outlived his span of carcinoma stomach expected lifespan.
Yes, he's used up all his years.
So would you like to revise your differentials the other way around, or would you still want to go with carcinoma of the distal stomach? Because the primary teaching when we learn at MBBS is in a malignancy, the stomach will not distend so much, even when the malignancy obstructs the stomach, because it is a fast disease, right? It's a galloping disease. So it does not allow so much distension. There is a submucosal infiltration. So largely classical gastric outlet obstruction will never be there in a CS stomach.
Yes, ma'am.
Most probably.
Most probably.
It's very rare.
Certainly with not such a large stomach. I mean,
Yes,
I would bet very highly on that.
Most of the examiners are yet to see such a distended stomach with gastric outlet obstruction due to malignancy. Most of the examiners.
Yes, yes.
This can be, we don't know. But then let it be. Don't read the CT scan report. This is what I am telling you.
Yes, sir. At this stage, actually, sir, I was confused even whether it would be benign etiology, chronic benign etiology, or a malignant etiology.
Then the CT change your mind. This is what I am presuming.
No, sir. In this stage, I was putting a malignant etiology to the first place just because of a loss of appetite, loss of weight. Even the patient was saying, I used to be
loss of weight. His BMI is 20. How can
yes, sir.
And that is not measurable. You have said that is not measurable.
He was initially healthy. Sir. He was initially, yes, sir. It can be because of vomiting.
Whatever it is, it can't be 20 in CS stomach. Why is the weight loss in CS stomach?
Sir, because of the loss of appetite and also the loss of weight, sir, in the malignancy, the malignant cachexia.
Loss of appetite, there's a lot of, even in hepatitis, you get loss of weight. So?
Because
what is the basis of weight loss?
In any malignancy, why?
Because there is decreased absorption of the nutrients and there is
there's cachexia, the whole is
malignant. Yes, sir. Malignant cachexia.
The malignant cells are using up all the nutrition.
Using up.
Right. Not because of this. Some element is there, of course.
Okay, so we are arguing back and forth whether it's benign or malignant. We all want you to say benign. You want to stick to malignancy. Okay, so
but at postgraduate level, Dr. Ramya, I will not accept the diagnosis of malignancy as the first diagnosis with the history and the findings. Absolutely. So I think we have to go with the most common first.
But logic.
Yeah, because logically what fits with the history and the findings. Okay.
Yes, ma'am. But for the chronic peptic ulcer, which is the which is the most common for this classical gastric outlet obstruction, ma'am, patient is not having any history of history suggesting of this peptic ulcer in the past.
This is what
over-the-counter medication they take it. Yeah,
he is not having any chronic drug intake.
Yes, many patients come without history of peptic ulcer disease.
Because they may not have the classical symptoms, you see.
Yes.
They'll have some vague dyspepsia. They think it's indigestion.
Yeah, and our patients also tolerate a lot. So many a times they don't even consider going to a doctor. They modify their eating habits. They keep changing things. And then they don't even know that they are supposed to report these.
Yes. They take Eno and soda and whatnot.
Yeah.
Remember one dictum, if you diagnose the rare disease, you are rarely correct.
Yes, absolutely. And you have to go by what the theory and the findings should match.
Apply your logic of history, examination, and all findings. Don't read reports. Reports may say 180 degree of your probable diagnosis. It doesn't matter for all examiners. Your logic of working in wards and OPD and OT for so many months to years, right? This is what you should apply for. See, each and every examiner hints you that you should not put a probable malignant diagnosis as a first diagnosis. It can come out on investigation. That doesn't matter.
Okay, so how will you investigate and prove it to us, or you? Either way, it is better to put chronic peptic ulcer disease resulting in GOO as your first possibility. We can always change. Keep your mind open. Don't be so resistant. And it doesn't logically fit in. This is carcinoma stomach. So still, it could be a possibility, as Dr. Hitesh said, very rarely. That okay, if it comes out to be, you should know how to manage that. That's fine. That is accepted. So how will you investigate this patient and how will you manage this patient in the ward?
Investigations, ma'am, to confirm and support my diagnosis, would like to go with upper GI endoscopy and biopsy, ma'am.
Will you do the upper GI endoscopy? What is the timing of the upper GI endoscopy? You saw the patient in OPD. You admit the patient today. So when do you want to do the endoscopy?
The next day morning, ma'am. After
you're very fast, just like your presentation.
Yes, yes.
Today morning, you put the right endoscope. What will you see?
What will you see? What will happen when you put in your endoscope?
Hey, ma'am, I do a first. Today I'm admitting the case and I do a gastric lavage, and the next day morning, then I go ahead.
Again, everything won't appear so fast. It won't.
How long will you have to do gastric lavage?
Until the clear
how do you know your gastric lavage is sufficient?
Until the clear fluid is obtained.
How do you know your gastric lavage?
Until the saline is obtained, sir.
Right. So you think you keep on doing it?
A large bore Ryle's tube usually you need, right? Maybe 18-20.
Yes, sir. Yes, sir.
So you can't do gastric endoscopy next day.
Okay, sir.
The whole stomach is boggy and inflamed. It's edematous. You will not be able to. You'll cause more damage and bleeding. You can't do it the next day. Also, what is the patient's electrolyte condition just now? What is his hydration and what is paradoxical aciduria?
Yes, sir. In gastric outlet obstruction due to repeated vomitings, he is losing acid and he is in hypokalemic metabolic alkalosis, sir. But to conserve the potassium, the kidneys try to conserve the potassium and leaves H+ in against, and so there is paradoxical aciduria, sir.
No. What does the kidney do? How does it conserve?
So initially there is
conserve potassium.
No, sir. It initially
no. Kidneys want to conserve potassium.
Sir, initially there is.
How does kidneys?
Sir, because the acid is lost and there is alkalosis, the kidneys they excrete bicarbonate and to conserve for the alkalosis, sir, the compensation is they excrete the bicarbonate and also sodium. And reverse then the sodium is absorbed inside, then the potassium is the Na plus H+ K+ exchanger, so the H+ is lost, sir.
Dr. Asha, you're totally confused. You confused me also. Look, the patient is dehydrated.
Yes, sir.
Isn't it?
Aldosterone is released and
so
it will.
Listen. Now listen.
So what does the body want? It wants water.
Conserve water.
That is the most important. Sodium, potassium, bicarbonate, hydrogen are secondary. Most important is water. Now, how does kidneys conserve water?
By aldosterone, sir. And
right. So what does aldosterone do?
It will reabsorb water and so.
Water cannot be
sodium,
reabsorbed on its own.
Sodium, sir. Alone.
Right. So sodium is a positive ion.
Yes, sir.
Now, it has to be exchanged with another positive ion.
Yes, sir.
Which are the positive ions it has got in this at disposal?
Is it potassium or hydrogen? Yes.
Hydrogen. So it's the hydrogen which is coming out in the urine.
Yes, sir.
Right. So the body is alkalosed, but hydrogen ion is coming out.
That's paradoxical.
So aciduria. Yes. This is paradox. So what fluid will you give?
Sir?
How will you
resuscitation.
reverse this paradox
How will you rehydrate the patient, resuscitate?
Yeah. How will you rehydrate?
So NS with a normal saline and
NS, why not RL?
so sodium, if we give, then kidney will stop this sodium and potassium H plus exchange, sir. So that
Right. The body wants water and sodium.
yes.
So if you give the body water it wants, give it water and sodium. Simple. You can give RL also,
Yes.
but normal saline is best. Okay. Yeah, please.
So the message is
Ma'am?
you hydrate the patient, resuscitate the patient, wait for the edema to settle, give at least 48 hours to 72 hours. Don't be in a hurry. Then you do the endoscope. Then you'll be able to visualize the mucosa, visualize any lesion. Biopsy will be safer. It won't bleed. There won't be any oozing. And see what is the most important thing in the upper GI endoscope you want to see in this patient. Okay, you prepared 72 hours, ho gaya, you're doing the endoscope. So
Yes,
what
ma'am.
is it that you're looking for?
I would be looking for any ulcer or any growth, ma'am. I would be looking for changes, any
What
chronic
investigations
changes.
will you do before doing an ultrasound? Before doing an endoscope?
So routine blood investigations and viral markers, sir.
Okay. And what about an ultrasound?
Yes, sir. Ultrasound, I would definitely prefer an ultrasound because it's an
What
extension
about
for my
X-ray
clinical.
abdomen erect?
Yes,
Will you
sir.
do that? So these are basic investigations you have to do before you go in for endoscopy.
Yes.
Endoscopy is not a priority here. It's not bleeding. There's no
Yes.
hematemesis, right?
Yes, sir.
So why are you jumping to endoscopy first? Right?
Yes.
Okay. So ma'am asked you 72 hours, you've done an endoscopy. What are you looking for now?
I would be interested to see if there is any chronic changes, sir, like any chronic ulcer or any growth. And
What will the finding in gastric outlet obstruction? Any gastric
there will
outlet
be a
obstruction, irrespective
largely
of-
dilated stomach, sir,
Yes, yes.
with a distal obstruction, which
So how does
No,
the
no,
dilated stomach look on endoscopy? How does
the
it
loss
dilated-
of rugal folds.
Right. The rugal folds will be smooth, ironed out.
I don't know.
What usually you get findings from gastroenterologist or the person doing endoscopy is
Scope, whether it is passed beyond
cannot
the
be negotiated. Yes,
negotiated
pylorus
beyond
does not open.
open.
Right? It is a
Yes, sir.
other findings. Now you think of the disease and do it.
Yes, sir. We
What else?
Should also look for a deformed pylorus,
deformed
right?
Yes.
yes, ma'am.
That will indicate
Into the
a
chronic
chronic ulcer. Yeah.
How often do you see an ulcer in patients of gastric outlet obstruction due to peptic ulcer disease?
Correct.
it will be usually deformities, ma'am, which is chronic rather
Where
than the
do-
active
Where
ulcer.
do you
Usually the
expect
ulcer is healed.
Where do you expect the ulcer?
Yeah. Where do you expect it to be, if at all?
In the lesser curvature, ma'am, benign.
No. Organ.
No. It's a gastric outlet obstruction, right?
It being stomach?
Gastric ulcer, yes, sir.
No.
So, but the scope couldn't be passed.
So that is why you may not see any ulcer. You may see
Okay,
just deformed
Pylorus.
And even otherwise, it may have been replaced by fibrosis. The
Fibrosis.
ulcer eventually has healed most of the times.
Yes.
Yes, ma'am.
So you will not be able to appreciate an ulcer crater like you do in patients of hematemesis sometimes that bleed
Yes,
due
ma'am.
to ulcer.
Yes. Will you take biopsy if you don't see ulcer?
Yes, sir.
Yes. From where?
So, in different quadrants, sir, around 6 to 8 biopsies, sir.
For what reason you want biopsy if you're not seeing ulcer?
Ma'am, it may be the subserosal infiltration, which we can't see mucosally.
What is the technique to achieve a biopsy in a subserosal infiltration?
Ma'am, we can use a narrowband imaging or a
No. For a biopsy, there is a specific
Endoscopic
technique.
biopsy.
Endoscopic
Endoscopy.
biopsy. There is a specific technique if you're suspecting submucosal, right? That's what you're saying, submucosal infiltration, and the mucosa is looking normal. What is that technique called? It will not help you to take at multiple places. You will have to do a well technique whereby in the same place you will take deeper biopsies. And that you may repeat at 2 or 3 quadrants.
Okay, Dr. Asha.
But suppose this is not malignancy, then also would you like to take a biopsy if you are not seeing any ulcer? That is the question. And why?
Yes, ma'am.
Why?
Any dysplastic changes, ma'am, in the normal mucosa
No.
itself?
No. Would you like to look for H. pylori?
Yes, yes, ma'am. Yes, ma'am. Good. Yes, ma'am.
Dr. Asha, when they're doing an endoscopy,
Yes,
they
sir.
press onto the wall of the stomach. Where there is malignancy and infiltration, the stomach will not indent.
Yes, sir. To look for
A
distensibility.
normal wall will indent. So they take the biopsies from this point where it doesn't indent. How many biopsies are taken usually?
6 to 8, sir.
Yeah, good.
Then what? You don't find any growth. Now what will you do? You have taken biopsy for H. pylori and all. Now what will you do?
I would try to place a nasogastric tube endoscopically, sir.
That's
if
fine.
possible.
That is already kept to give lavage. Not an
No,
issue.
sir.
You can
Beyond the
put it.
pylorus.
Now, investigation point of view, evaluation point of view.
After upper GI endoscopy, sir.
Yes, yes. You don't find any growth. The biopsy also is negative.
Okay, sir.
Now what?
Biopsy is negative for malignancy, sir.
Yes, yes.
Can you do something to find out if you are missing something?
Sir, I would like to go ahead for CECT abdomen.
No, endoscopically.
Endoscopically, sir.
Any additional investigation by endoscopy?
Chromoendoscopy to identify any.
No. Simple thing.
Simple.
Endoscopy is a screening
Endoscopic
test.
ultrasound, sir. To
Yeah.
Right.
look for.
So you do
Yeah.
endoscopic. Yeah, right?
Yes.
If endoscopic ultrasound is normal, not suggesting any growth, and regular ultrasound is also normal, do you need CT scan before treating gastric outlet obstruction?
Yes, sir.
No.
No, you don't need it.
No.
There is external compression.
No. See, that will be seen on US. US has maximum yield as far as this missing growths are concerned. Even if you don't see any head pancreas mass on CT, US might give you some hint that there is a mass, a smaller mass, and you can take biopsy. It is that much sensitive, right?
Okay,
So you don't need.
Okay, sir.
How will you treat? Diagnosis now, according to all the examiners, is a gastric outlet obstruction secondary to peptic ulcer disease.
Okay, sir. Okay, ma'am.
So now what will you do?
So how will you, what will you do?
Ma'am, I would like to.
Is it curable, incurable?
It's curable, ma'am.
What is curable?
I mean, we can make a path drainage procedure.
What
Because
will
you were thinking, I had to ask that question. So what will be your plan for management?
The drainage procedure, ma'am.
What specify?
Sir, pyloroplasty or yeah, we can go for gastrojejunectomy.
What is preferred?
Gastrojejunectomy.
What is the primary problem? You're not addressing it. What caused the
Yeah.
ulcer?
What caused the ulcer?
Ulcer.
Yes, sir. H.
Where
pylori
is the ulcer?
eradication.
Most probably in D1.
Yes,
D1.
There's no H. pylori. Dr. Hitesh already said it's negative for H. pylori. What is the purpose of doing drainage? What you're trying to do by doing drainage procedure? What is the key problem?
Bile and
Ilama, what causes the ulcer?
Ulcer.
The cause for peptic ulcer in this patient.
He may not have symptoms, but what is the reason of developing peptic ulcer?
acidic, hyperacidic secretion.
So what do you want to do
What
for the
will be the
hyperacidity? You have
procedure?
not told us anything.
Sorry, ma'am. Highly selective vagotomy.
Why highly
Why are you doing
specific?
drainage procedure then? Simple answer part, truncal vagotomy.
Truncal vagotomy.
As a role. If you're doing highly selective vagotomy, you don't need to do a drainage procedure. So you should not say controversy.
Okay.
This patient is not a candidate for highly selective vagotomy because he already has a
Exactly.
dilated with an
Exactly.
outlet obstruction.
Okay.
So
Yes.
he is only for truncal vagotomy and a gastric
Gastrojejunectomy.
drainage.
drainage procedure.
Any
What
other
type of
surgical
gastro-
option?
Any other procedures we can do?
Any other
other than
surgical
this
option?
gastric
Yes.
surgery?
Procedure which you can do or used to be done in past?
Antrectomy or
And what is that procedure known as? What do you?
so Hill's procedure.
No.
Talus.
Which you were
Very
talking
famous
of past
surgeon.
history
Very
of
famous.
surgical procedure.
Bilroth.
Very famous surgeon.
Yes,
Yeah.
yes.
Bill Roth.
One or two?
So gastroduodenotomy, sir. Initially they used to do one
No. Here we
antrectomy. Here
Okay.
we will do two, sir.
Okay.
Two.
What do you do in Builder 2?
So we will take a 15 to 20 centimeter jejunum from the gastroduodenal
What will
ligament.
you cut first
What
before
you
do
excise?
this?
From
What
where
will you
to
cut
where?
before you do? You started on reconstruction without surgery.
The distal stomach, sir, and the
How much of the stomach? How much distal?
3 centimeter from the pylorus, sir. 4
You'll
proximal.
measure it. You'll measure it. From where?
Incisura angularis to the opposite side.
Yeah, incisura, right. So from the incisura, right?
Yes.
Okay. Anything before doing all this? Any endoscopic procedure which you can do?
So
Any
endoscopical
balloon dilatation?
stenting
Endoscopic balloon dilatation?
can be tried, sir, but
Yeah, you can try. Right? Okay. So how will you reconstruct now? You've done a Bilrot or you've done a Bilrot 2, right?
yes, sir.
So how do you reconstruct now?
And what will you close?
What do you close and how do you reconstruct?
Duodenal stump is closed, sir, and the jejunum from 15 to 20 centimeter from the
Hang on.
sir.
What do they say exactly? How much should be the jejunal stump?
15 to 20 centimeter from the DJ.
Okay, usually short jejunal stump.
Short. Yes.
Stump. Now will you go anterior or posterior? How will you get the jejunal stump to the stomach?
Anterior, sir.
Through what? How will the jejunum reach the stomach?
So anteriorly.
Will you go through any mesentery?
So if it's posterior, then we will go through transverse mesocolon. Sir.
Right.
In general, posterior
Is preferred.
anastomosis is preferred unless
Why?
you are treating for a palliation of malignant conditions. Any.
Why can't you do it in malignant condition? Can't be a posterior because
So,
posterior is generally
because it's it
is adherent.
posterior, though it is a better dependent drainage procedure, we are mixing the supracolic and infracolic compartments, thereby promoting the spread. And also in malignant.
No, is that the main reason?
No,
That's
ma'am,
the
if the lymph nodes, if present, they will enlarge and they can cause compression of the anastomosis. And even in redoing the
Stomach,
procedure.
in malignancy,
No.
it's very difficult to reach the posterior stomach. It's all adherent.
Okay.
You can't reach there.
There is
Right.
shortening of the mesocolon. There may be
Shortening of
infiltration outside. So it's very difficult to dissect there. You will be causing more problems. So the quickest anastomosis is
Anterior.
anticolic. Okay.
Anticolic.
And
Is it
that is the best. And the other thing is it may infiltrate. If you even manage to do a posterior, it's going to infiltrate that much faster
Sooner
than
or later. Yes.
So that is the reason.
Okay.
so? Is it isoperistatic or retroperistatic?
Isoperistaltic.
Okay, so how do you take this?
Describe the surgery. What is a mnemonic used for it?
Mnemonic.
Okay, I will tell you. It's PV ring. Posterior, vertical, retrocolic, iso or isoperistaltic, no loop or
No
short
loop.
loop,
Right.
jejunostomy.
No
This tells everything out. What was the mnemonic, man?
PV ring.
PV ring.
PV
PV ring, RING.
ring. Okay.
Good one. Good one.
But one question, Dr. Asha, would you like to do some modification for the gastrojejunostomy? Now that we are considering that he is a what are we labeling him as? Adult, not old age.
Middle age.
Middle age, ma'am.
Yeah, middle age. So would you like to modify your gastrojejunostomy?
Roux and why?
Who and why? Yes. Very good. And why?
The bile reflex can be reduced, ma'am. And,
Yeah.
Yes.
So bile gastritis can make some patient's life really miserable. So in a benign condition, and when you're expecting some life survival for the patient, Ruavai may be a better option for him other than a regular gastrojejunostomy.
Okay, Dr. Asha, quick complications of this?
So complications of
Surgery.
With surgery.
So
Quick.
bleeding.
Come on, all surgeries lead to bleeding. Not a bad surgery.
So
Don't give
dumping
me bleeding
syndromes.
infection, bleeding infection. Yeah, dumping.
You have done Billroth too. What complication do you expect?
Earlier, most common stump blow.
Duodenal.
Stump
What do you
blow.
call it?
Duodenal stump
blowout.
blowout.
How can you treat it?
Should re-explore and
It can be kept conservative. It may
drain can be
if it-
placed,
right? Or you can put a duodenostomy through the stump. You can close it over it. Okay. Other complications of gastrojejunostomy?
so classical dumping syndrome, so early and late dumping syndromes.
Then, if you have not done vagotomy, then if a junior surgeon does only gastrojejunostomy and doesn't deal with the hyperacidic condition, what can happen?
Recurrent
It can be
ulcers.
fatal. It can be fatal.
Jejunal ulcers.
There can be stomal ulcers and it can bleed.
Okay. Afferent loop syndrome, and most important is
Afferent loop syndrome.
retrograde jejunal intersusception, which is
Yes, sir.
which can be
Retrograde.
fatal.
Yes, sir. Jejunal intersusception.
So should we go? I think we crossed the time.
Yes.
Sir,
Yeah, I think we can wind up, sir.
Yes, madam. Dr. Asha, do you have any doubts or any questions to be clarified by the examiners?
Sir, in such cases, sir, where the duration is less and the patient is having a significant weight loss, sir, as he was saying, his clots were even loosened, and he is not having any past history even on probing. Sir, how can we justify a benign condition, sir, if we take the first readings in exams?
I'll tell you, Dr. Asha, you cannot justify malignancy. That is why you should keep benign. It is not that you cannot justify the benign disease. By no means you can rule stamp that this is malignancy as per your history and examination finding, particularly of huge J-shaped hanging stomach up to pelvis. If Madam told you, I think Ramya Madam or Aparna Madam told you that what is the survival of CS stomach for this
without
stomach to become, patient would not have survived, right? Only loosening, and he did not look that much emaciated, right?
Yes.
If a CS stomach with outlet obstruction patient presents to you, you will be seeing only stomach in the abdomen, nothing else, right? So this is what
it's better to go for a benign condition.
One more thing I want to tell you.
I don't know what
such things may come in your exam that you should redefine your summary or findings. Then there can be two cases. Sometimes you have done so good that examiner is checking your confidence. Just make sure what you are dealing with, right? Don't just change if one of the examiner does not agree with your finding. Just don't change your diagnosis immediately. Think whether he is testing your confidence or not, and be prepared with the worst possibility of what you have not prepared at all, benign gastric outlet obstruction. When you are dealing with gastric disease, think of all possible diseases and be prepared to answer, right?
Yes.
Yeah, I don't know what was the endoscopic and CT findings, but I think it's time's up, so we'll discuss it later.
Yeah.
Yeah, thank you very much.
Focus on reading daily love. That is all.
Lord, that this man. And this were the...
Can I make a comment now?
Yes, ma'am. Yes, sir. Please, sir.
Actually, this case was discussed in our clinical meeting also, our departmental clinical meeting. And there was a big tussle going on between whether it is a benign or the malignant one. You know, it is correct that the signs, they always overpower the symptoms here. And in this patient, the most important sign was there was a hugely dilated stomach was there. And there was no palpable lump. You know, lump which you have to feel in a case of suspected bloated stomach, which is there, is a lump in the right upper abdomen. Many times you can get, many times you can get, there's a localized type of the lump which is felt. And if you feel that lump in that area, then this is a patient with a carcinoma. But in this patient, such lump was not there. And that is why hugely dilated stomach, it is very correct what all the examiners said, that we should always keep a possibility of the benign pathology here because of that sign which is there. Okay, though on endoscopy and CT scan, it has come out to be a carcinoma of the stomach, but still probably on the clinical ground, it should be first possibility of a benign pathology rather than the malignant pathology.
Okay.
And in the malignant pathology, if you have to think, you know, Dr. Rajiv Saha was asking that which benign, with malignant pathology will not have the hematomesis melena, but there will be dilated stomach is there, then that is the localized type of the linitis plastica. That is a very typical type of the localized type of the linitis plastica, where you will find there's a lump in the right upper abdomen. You can feel that small lump, and there may be adequate dilatation of the stomach may be there. I'm not talking the generalized linitis plastica. I'm talking the localized linitis plastica, and the patient may not have any hematomesis or melena, but will be having a distended stomach. So that was another possibility which was coming out. Okay.
Dr. Asha, any malignant condition which you don't need surgery of stomach?
Lymphomas.
How will you take biopsy? We have already discussed, right? Aparna madam told you.
Well
biopsy. Yeah.
Go deep in that and take a deeper blood.
I think,
Okay, thank you very much.
Excuse me, we have one more long case to go.
Yes, yes.
Dr.
Okay,
Asha, you
sure,
did
sure.
well, and I definitely understand you are able to defend in spite of all the difficult presentation of this particular patient. So good luck to you, and I thank Kanna sir and Seema ma'am for permitting you to be part of this teaching program today. Thank you very much, Dr. Asha. You stay back for the next discussion also.
Yes, sir.
Dr. Shrikant?
Yes, sir.
Can you, Ashama, can you please unshare your screen? Yeah, thanks.
Yes, sir. Yes.
Yeah. Shrikant is from Sri Ramchandra Medical College, and he is a postgraduate from Professor Naveen Alexander sir's unit. The head of the department is Professor Balaji Singh. Thank you, Shrikant. Please make your screen full screen and start your presentation.
Yes, sir. A very good evening to one and all. Today I'm going to talk about a case of obstructive jaundice. Coming to the complaints, 75-year-old male came to the OPD, who is a retired army chief from Chennai, urine, eyes, and skin for the past 3 weeks. Coming to the history of present illness, patient was apparently normal 3 weeks ago, following which he developed yellowish discoloration of urine, eyes, skin for 3 weeks, which is gradual in onset and progressive in nature, associated with pale color stools and associated with itching all over the body. Patient also complains of the history of loss of appetite for 1 month and loss of weight for 1 month, around 6 kgs loss. Patient also complains of history of nausea, and there's no history of abdominal pain or vomiting. There's no history of postprandial fullness, no history of fever, malaise, chills, and rigor, no history of melena or hematomesis, no history of altered bowel habits, and no history of suggestive distant metastasis. Coming to the past history, patient is a known case of type 2 DM and systemic hypertension for the past 30 years and non-regular medication. And there is no history of pre-surgical history. surgical history in the past. Coming with the personal history, patient takes non-vegetarian diet and he's not a smoker or alcoholic. Family history, there's no history of similar illness in the family members. Treatment history, there's no history of blood transfusions, or there is no history of intake of native or herbal medicine previously. Coming to the summary, a 75-year-old male came with history of progressive jaundice for 3 weeks, associated with pale stools and itching, and loss of appetite and weight loss for 1 month. And this history is suggestive of obstructive jaundice, possibility of malignant etiology.
Shrikant, I'd like to point your attention, draw your attention to never say that I am presenting a case of obstructive jaundice. This is not right, as if you are preparing for exam. So you don't say like that, right?
Okay.
So begin with your history only.
Okay, sorry.
Okay, let's go back to your first slide now. You said it's a case of obstructive jaundice, probably malignant etiology. What are the points in history which is pointing out to this?
So, pointing towards malignancy, first thing is the age of the patient, sir.
No, good. Look, you should always go the other way. First, what is the jaundice? Is it obstructive or not?
So it's
then
an
you going for
obstructive jaundice.
benign or malignant causes. You can't go for malignant and then for obstructive jaundice. It's the other way.
Okay.
Right.
So the causes leading to obstructive jaundice, the first thing is the yellowish discoloration of urine, eyes, and skin, and associated with pale color stools and itching all over the body. So these are the 3 points which leading to the signs of obstructive jaundice, sir.
Okay. Why is there itching?
Sir, itching is...
What is so typical about the itching?
Sir,
Did you elaborate on the itching in your history?
Itching is like he complaints of itching like occasional episodes, sir, like all over the day.
What is characteristic of itching during obstructive jaundice?
It is mainly because of deposition of the bile salts.
That is the pathophysiology.
Okay.
I'm not asking you that. Does the itching in obstructive jaundice differ from itching because of other causes?
So itching in obstructive, it has a scratch. He'll have this marks tends to
that
scratch.
You have whenever there is itching.
Like it will be a non-stop, so like severe urge to itch, like
right. It is all the time, and more so that it disturbs the person's sleep.
Yes.
Person cannot sleep because of the itching. So did you ask him whether this itching was affecting his sleep pattern?
Sir, he is getting awake in between, sir.
You not mention it. No, you should mention it.
Okay, sir.
Right. Okay. Pale colored stools. Now,
Yes,
did you ask anything about pale colored stools?
Sir, and he gave this history clearly saying that that starting he used to.
I know who's given that. What do you ask about pale colored stools in cases of obstructive jaundice? You have to elaborate on it. You just can't say pale colored stools and walk away.
Is it a white? Or is it sticky or white?
That is the definition of pale colored stool. But is there any change in character?
No,
is it associated? Is it waxing and waning? Is the jaundice waxing and waning?
So he didn't complain of any waxing and waning of history.
But you've not mentioned it here, no? That's what I'm trying to ask. You've not mentioned it in history.
Okay. He didn't mention no history
about melena.
There is no history of melena or hematemesis. There is no history of altered bowel habits or.
No. Okay. Why did you ask for melena and hematemesis together? What will give rise to hematemesis in cases of obstructive jaundice?
Hematemesis is can be due to increase in portal hypertension, which can lead to varicose bleed and hematemesis. And the other thing is due to increase in
by the time the tumor causes portal hypertension and hematemesis, the patient would be dead. Melena is important. Portal hematemesis can happen when the tumor infiltrates into the stomach. Not because of portal hypertension.
Okay, sir.
Have you ever read about obstructive jaundice causing portal hypertension?
No.
Then why bring it over?
No.
Why does the patient have melena in a case of obstructive jaundice? How can he have melena?
So in obstructive jaundice, because of increase in the breakdown of the there's a increase in the bile salts, bile toxicity, so which causes a damage to the
Melena is simple bleeding from the GI tract, right?
Where is bile salt coming near?
So where is the bleeding happening in cases of obstructive jaundice?
from
If it happens,
from
does the
from the
tumor shed off once in a while? Suppose there is a periampullary tumor,
yes, ma'am.
it sometimes
So
sheds
there's,
off once in a
shed.
while. Then the jaundice reduces. Okay, and that time patient may have melena.
Another cause
Right.
is if there's a duodenal malignancy,
malignancy.
the mucosa sheds. The
Shedding.
malignancy is the oil in the duodenum,
Yes,
isn't it?
yes, sir.
Okay. No history of altered bowel and bladder habits. Why did you ask for that? What kind of altered bowel are you looking for?
It can
Why
be
did you ask for that?
sir, in obstructive jaundice for in obstructive, sir, in obstructive jaundice coming to the bladder habits, there can be chance of decreased urine output, sir, because of increase in the bilirubin levels, which causes deposition.
So what did you ask about bladder habit?
Bladder,
Did you ask
any
the question?
like any history of decreased urine output, sir. Decrease in the urine output.
That is oliguria, right?
Oliguria.
How did you ask for it? How did you ask for it? What question did you ask the patient to establish that there's no altered bowel and bladder habit?
So bladder habits, like compare it.
What are you looking for in bladder altered bladder habit? In the case of obstructive jaundice, what are you looking for in altered bladder habits?
To
Does
look for
it
this
cause any bladder outlet obstruction? How old is the patient?
70 years old.
So you tell me that I was asking for whether he's got any bladder outlet obstruction or not. It's nothing to do with your obstructive jaundice.
Okay. Because of this prostatoma.
Or not. What altered bowel?
Bladder is due to of prostate. Old age is common. Prostatomegaly is
Right.
common.
So that is why. So you give me the answer. Huh?
Yes.
Right. What about bowel?
In old age, common this constipation.
Not old age. Now this is related to obstruction. You don't put everything to old age, please, Srikanth. In obstructive jaundice, what happens?
There's chance of this fear.
No bile salts there.
Bile salts are there, so fat absorption will be less. So it causes steatorrhea.
You just can't open the book and because it says altered bowel bladder habits, you should know why you're asking for it.
Yes.
Postprandial fullness. What do you mean by that?
Like after eating, any signs of.
Why here? Why in obstructive jaundice? You said. Why in obstructive jaundice?
To rule out malignancy features, if it's obstructing, if it's periampullary carcinoma causing the obstruction of the D1, D2 segments, causing.
Periampullary carcinoma causing obstruction. Okay. It can press onto it, can infiltrate into the stomach and the ampullary. Okay. Fever, malaise, chills, and rigor. Why do you ask for that?
So to rule out acute condition like infective causes like cholangitis, or any history of CBD stone in the CBD.
So because of inflammation,
infection and inflammation.
Okay, next slide.
No.
Yeah, ma'am, please.
No, we'll go through this and then I ask. We'll go through this slide.
Okay, history of blood transfusion, native or herbal medicine intake. Why did you ask for that?
If there's a history of blood previous history of blood
transfusion got herbal medicines.
So herbal medicine or native medicine, it's chances of causing this jaundice, like they intake and they think it gets treated, but it won't, like causes some reaction with your blood and causing breakdown on hemolysis, hemoglobin breakdown.
Shrikant, kuch bhi bolte yaar. Yeah, they can cause cholestasis. There's someone's giving you the answer. There are some drugs which can cause cholestasis. कुछ भी दे दो यार, hemoglobin breakdown, कुछ बोल दे. Okay, next slide. Okay.
So my question, Dr. Shrikant, is that for a 75-year-old patient who has come to you with jaundice of 3 weeks duration,
yes, ma'am,
with the symptoms that you are saying, would you like to have a differential diagnosis, or would you like to label the patient as malignant etiology?
Ma'am,
the duration is 3 weeks.
Yes, ma'am. The duration is short duration, ma'am.
Yeah.
And again, the thing is 75 years old and associated with signs of that is one factor relating to malignant etiology. But we can also intake, because of this short duration, if patient is presented with prodromal symptoms like nausea, fever, malaise, then we can think of first thing can be viral hepatitis or stone in the. If patient is having pain, then we can think of CBD, distal CBD stone.
In viral hepatitis, can the patient have pale colored stools and itching?
No, ma'am.
No?
No, ma'am.
They can have. Any hepatitis at its beginning will have a cholestatic phase.
No.
So they can definitely have a period when there is pale colored stool and itching and loss of appetite, which is part of the viral illness.
No.
So that is one feasibility, but I agree with you that there is no prodrome, there is no nausea, there is no fever. So we may not take that as one of the diagnoses.
Yes.
Amongst the other diagnoses of jaundice, possibly obstructive. Would you like him to be labeled at the go as a malignancy? Is what I'm asking.
I didn't get you, ma'am.
Patient has come to you with a 3-week history of jaundice.
Yes, ma'am.
What are the causes of obstructive jaundice? That's what
are the other causes of obstructive jaundice? That you should be putting them here as a differential. You have not even gone up to the examination finding. So this is a summary of your history.
Ma'am,
history.
Yes, ma'am. Coming to the causes of obstructive jaundice, ma'am, it is divided into three types. Coming to the luminal clause, wall, and the extraluminal clauses. Coming to the luminal clauses, it can be.
We can't please. This is not a written exam. There are 3 causes, 3 luminal. Just tell me the.
Yes, sir. Luminal causes something he can form, sir. And wall, which includes the C head of pancreas or chronic pancreatitis or stone in the CBD.
CBD is one. Okay, next one.
Biliary stricture, sir.
2. Others. Go on.
Primary sclerosing cholangitis. That is one.
Okay, sclerosing cholangitis.
Choledochal cyst.
Choledochal cyst. Anything important? Parasitic infections.
Worms, ascaris, which is one of the most, and cholera cases, which is one causing this.
Okay. And of course, lymph nodes, because of any other reason.
Yes. Very good.
Did you ask about the history of night blindness in this patient?
Sir, no, sir.
Any patient of jaundice may have the night blindness?
Yes, sir. There's a chance of having night blindness in in jaundice, sir, because of this bilirubin is not present, so there's no fat soluble vitamins not they won't get absorbed like vitamin A, D, E, K. So deficiency of vitamin A causes this night blindness.
No? So you must ask about because 10% of the patients with obstructive jaundice may have the night blindness. If you carefully ask the history, that history will be there.
Okay.
What is the difference between waxing waning jaundice and intermittent jaundice?
So waxing and waning indicates that there is a sudden drop in the bilirubin levels, but still the patient has jaundice. Whereas interval jaundice is where there is interval period, there is no jaundice at all.
Can you give the example of the waxing waning jaundice?
So in waxing and waning, most common example is periampullary carcinoma, sir.
Any other carcinoma which can give that?
In C head of pancreas, sir.
What is Klatskin tumor?
Klatskin tumor is it's a variant of cholangiocarcinoma, which is arising from the junction of the right and left hepatic.
So can you have the waxing waning jaundice in that?
Yes, sir. We can have, sir.
Oh, and what are the examples of the intermittent jaundice?
So most common example is stone in the distal CBD.
Yes.
And parasitic infestations like ascaris, that can also be an example.
So can you tell that the sclera is yellow but the urine is white? Can it happen in a jaundice patient?
Yes, sir. It can happen in jaundice, sir. In prehepatic causes, other name is hemolytic anemia.
What is that jaundice called as? What is the name of that jaundice called as?
Hemolytic jaundice.
Acoloric jaundice.
Acoloric jaundice.
Acoloric. Okay. Can a blood transfusion can cause the jaundice?
Yes, sir. It can cause jaundice, sir. If a mismatch group transfusion or multiple blood transfusions,
so when it causes jaundice,
sir.
When a blood transfusion can cause a jaundice, when it will appear?
Sir, after 24 hours of transfusion.
Okay. And then any time after?
48 hours.
Any time after?
Any time, sir.
Cause for that jaundice? Okay, if it is causing the hemolysis, it will be within 24-48 hours, isn't it?
Yes, sir.
So can it after 6 weeks, 8 weeks?
No, sir. Sir, it can happen, sir, because the lifetime of RBC is 120 days.
No, that will happen immediately. If the hemolysis is there, it will be within 24-48 hours. What are the things you test when you are doing the blood transfusion in the blood?
So we'll look for the group and this. Either it's a positive or negative.
Anything can get transmitted.
Malaria, ma'am, which is one of the most common.
Malaria.
Anything else which you do?
RH typing, compatibility.
Hepatitis, है ना? Simple say hepatitis.
Hepatitis.
Okay, and that will present in 6 to 8 weeks time. है ना? Okay, so transfusion related hepatitis. Okay.
So then we go to examination findings. What next?
Yes,
yeah, you can go to examination. Yeah.
Coming to the general examination, after informed consent and the patient was examined under adequate light exposure with a BMI of 21.22 kg per meter square and ECU score of 1. Patient is having a icterosis positive. There are no pallor, sinuses, clubbing, lymphadenopathy or pedal edema, no palpable left supraclavicular lymph node, no signs of liver cell failure. Examination of vitals, pulse rate is 68 per minute, BP 130 by 80 mm of Hg. Examine right arm supine position, and the patient is febrile. Coming to the examination of abdomen. On inspection, abdomen is normally in shape, umbilicus is center and inverted, all quadrants move equal with respiration. Skin shows yellowish discoloration with a few scratch marks present over the abdomen. There are no dilated veins or scars. A vague mass is seen in the right hypochondrium, no visible peristalsis, and flanks are free. Hernial sites are free and external genital is normal. On palpation, there's no warmth, soft, non-tender, no guarding or rigidity. Gallbubble palpable in the right hypochondrium. Hepatopangal is present and no splenomegaly. On percussion, the upper limit of liver dullness felt in fifth intercostal space with a liver span of 14 centimeters. Dullness continued over the gallbladder. Renal angles are free and no free fluid noted. On auscultation, bowel sounds are heard. On rectal examination, the tone is normal, no growth palpable or pelvic deposits, fecal staining plus noted. Other systemic examinations are normal. Coming to the summary, 75-year-old male came with a history of progressive jaundice for 3 weeks, associated with pale stools and itching, and progressive with loss of appetite and weight for 1 month. And on examination, icterus is present, gallbladder is palpable, and no free fluid noted in the abdomen, and no palpable lymphadenopathy. Coming to the differential diagnosis, obstructive jaundice due to first diagnosis will be CA head of pancreas, periampullary carcinoma, cholangiocarcinoma.
Okay. Shrikant.
Sure.
The DDSCA head of pancreas, periampullary and cholangiocarcinoma. Now, how will you distinguish between, what are the distinguishing factors between clinically CA head of pancreas and periampullary carcinoma?
Sir, first in periampullary carcinoma, there will be a history of waxing and weaning effects, sir. Whereas coming to the CA head of pancreas,
what do you mean by periampullary carcinoma? What are the things which are considered periampullary carcinoma?
Sir, in periampullary carcinoma includes the cancer which is in distal part of the CVD, ampulla of water, and duodenum.
Around 2 centimeters of the ampulla.
Ampulla of water. Sir.
Right. So, do you think now what are the things? Distal head of, what are the
distal
components?
Are ampulla of water, duodenum, and distal 2 centimeter and distal part of CBD.
So you think there'll be waxing and waning if there is of jaundice, if there is duodenal carcinoma? Waxing and waning is a characteristic of CA of ampulla of water.
Ampulla water.
Not periampullary carcinoma. It's
okay,
ampulla of water. Okay? Because when malignant tissue becomes so large, more than 2 centimeters, the blood supply is decreased. It gets necrosis and falls off. Right? Okay, yes. What else? So that's out.
Sir?
In which conditions will you get vomiting? In which periampullary carcinoma will you get vomiting?
Sir, in a duodenal part, which is completely luminal obstruction, which causes vomiting, sir.
So duodenal carcinoma and CA head of pancreas.
CA head of pancreas.
Will you get vomiting in the other two, CA cholangiocarcinoma? You will not.
Okay.
Okay. In which periampullary carcinoma will be painful?
Painful, sir. When it is involving this,
which periampullary carcinoma is painful? Very painful. In fact, patients, they complain with a lot of pain.
Involving the ampulla of water with 2 centimeters.
No. CA head of pancreas. CA head of pancreas is
painful. CA head of pancreas will be painful, sir.
Okay. Please, ma'am. So, okay, how will you manage this patient now? You've got a patient. You think it's obstructive jaundice because of malignancy. How will you go about it now?
So coming to the management.
What is the type of the gallbladder here? Can you just describe the type of the gallbladder which is there in this patient?
So the gallbladder is soft and globular in shape, which is moving with the respiration, sir.
Now, in this patient, the differential diagnosis, would you like to keep a possibility of the carcinoma gallbladder?
So yes, we can keep it, possibility of carcinoma gallbladder, sir. But on clinical examination, if we feel the gallbladder, it will be like hard, and there chance it will be hard, sir. But when we clinical examine, it's not that hard. The gallbladder is not hard; it's soft, and so that's why it's included in.
So, is it always that the carcinoma gallbladder will be, you will be feeling the hard fundus of the gallbladder in all cases?
Not very ampullary carcinomas, do they present with a mass?
Sir, no, sir. No,
Other than gallbladder? They can. The head of pancreas can, but it's much late.
Much
late.
No.
I can feel even the lymph nodes.
Lymph node.
So they can. They can. Don't say they can't.
Yes. In CA gallbladder, what are the various types of palpable gallbladder? In CA gallbladder.
Okay, yeah. What are the causes of palpable gallbladder and CA gallbladder?
The types of the gallbladder. Yeah. If it is arising from the fundus, what will happen? If it is arising from the neck, what will happen?
No idea.
Now, if it is on the fundus, it will be hard gallbladder, isn't it? You will feel a hard gallbladder. But if it is from the neck is there, then it forms a mucocele. Okay, so it will be smooth gallbladder. Just like in a case of periampullary carcinoma, similar type of you can feel in that. So that is why always, at least in the northern states, if it is there, you will always keep a possibility of in parallel to the head of pancreas, the carcinoma gallbladder, which is arising from the neck of the gallbladder. Okay. So can you tell that what are the causes of jaundice in a patient with a carcinoma gallbladder? What are the various ways it can cause the jaundice?
One thing, it can involve the nodes, portohepatic nodes it can involve, or otherwise the direct involvement of the distal part of CBD. The tumor can grow.
Right. Any other causes for that? There are 5 or 6 causes for that. Jaundice in carcinoma gallbladder. Okay, lymph nodes in the portohepatis, you rightly said that. Compression of the bile duct by the tumor itself. Invasion of the bile duct by the tumor. Okay. Liver metastases are multiple. There is a solitary metastasis which can cause the jaundice. Can you tell that? Where can be solitary metastasis which can cause the jaundice in carcinoma gallbladder? Yeah, if it in the caudate lobe is there. Okay, there is a solitary metastasis in the caudate lobe is there, then that can also cause the jaundice. And then in about 10% of the cases, you have the choledocholithiasis. So these are 6 causes of jaundice in a patient with a carcinoma gallbladder. Okay.
So, Dr. Shrikant, suppose in this patient, you did not have a palpable gallbladder. For the sake of discussion, what then would be your list of differential diagnosis?
One can be this sclerosing cholangitis, ma'am.
Sclerosing cholangitis. What disease is that?
Sorry.
What is the etiology of sclerosing cholangitis?
It can be a primary or secondary. Primary is unknown, whereas secondary is mainly due to the stones, which causes stricture.
So we are talking of primary sclerosing cholangitis, right?
Yes, ma'am.
So that is a condition which is extremely rare. So when you are putting a list of differential diagnosis, rare should come lower.
Okay.
We should talk about the more common things. So anything you would like to put highest up on the list? All the other history and examination findings are same, but there is no gallbladder palpable.
I mean,
You already answered questions pertaining to those diagnoses.
choledochal system.
So what I am asking you is, what are the vagaries of Courvoisier's law? What is Courvoisier's law?
Courvoisier's law is like there's a palpable GB in case of obstruction, which is seen only in the malignancy. But apart from that malignancy, there are other conditions where the palpable GB is seen. One is double impaction of the stone.
Shrikant.
Sir.
Give us the correct Courvoisier's law.
Yes, yes. So all MS students should be able to say Courvoisier's law perfect.
Yeah. What did the law say verbatim?
The gallbladder will be palpable when it.
In a case of jaundice, if the patient has a palpable gallbladder, then it is usually not due to stones. That's it. That's what he said.
Coming to the exceptions are that the stone when it involving the neck of the GB, double impact stone, and increase and the pancreatic ample of water. So where we can feel a
That is where you will still have a gallbladder, but not because of a malignant cause. And I am asking you, what will be the situations where all other history and findings are proper? Probably there is malignancy, but gallbladder is not palpable.
Ma'am, in case of post-lab cholecystectomy with periampullary carcinoma, there is one where we can.
Okay. 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 Anything else? The gallbladder is still inside the patient. Patient is lucky. In a hilar cholangiocarcinoma, will the gallbladder dilate?
No, ma'am. That is
or if there is a periampullary with a chronic cholecystitis, also the gallbladder may not dilate.
Yes, ma'am.
No rocket science. You just have to think logically, and these are not trick questions. So you have to stop thinking that there is a trick question.
So,
okay, right, sir. So please. Okay, Shrikant, how will you go about this now? You've got a patient.
Yes.
You've seen it in clinic. You think it's surgical obstructive jaundice. What do you do now?
So first I'll do the routine. After admitting, I'll do the routine blood investigations, CBC, LFT, and coagulation profile. Followed by that, I'll do an ultrasound abdomen for the patient. So after ultrasound abdomen,
you're going to prove.
I'll decide.
You're going to prove by investigation, Shrikant. You're going to prove by investigation that it's an obstructive jaundice.
Okay.
What investigations will tell you in blood that is obstructive jaundice?
So one, it will be the first LFT, so it will be deranged elevation level of total bilirubin and direct bilirubin, and elevated of alkaline phosphate, with mild elevation of the liver enzymes, SCOT and SCO, alkaline transferase.
Okay.
And coming to the blood picture, hemoglobin may be low in cases of malignancy, and total count might be raised if it's case of if there's an infective etiology, the total count will be raised, and the proton time will be deranged in case of obstructive jaundice.
Okay, what else?
Shrikant, you are not interested to make a diagnosis here?
Sir?
You are not interested to make a diagnosis? That should be your first thing, Any
Investigation
physician or
should-
surgeon, he has to make first the diagnosis.
Yes, sir.
So what are you going to do for that? Blood investigations?
For the ultrasound abdomen and CACT abdomen, sir.
Straight away CT.
Ultrasound of the abdomen, okay.
Ultrasound. Why-
Not
why
the
CT?
CT scan.
Oh.
In a jaundice patient, there is no option. You have to do the ultrasound.
Yes,
Can
sir.
you differentiate between whether it is a hepatocellular jaundice or whether it is a surgical jaundice by ultrasound?
Okay, Srikanth, what will you look for in an ultrasound in a case of surgical jaundice?
So first, we'll look at, we'll start with liver. One will be intrahepatic biliary radical dilatation to be there, followed by the gallbladder will be enlarged and CBD dilatation. So what we'll look at for
Okay,
CBD.
hang on, Srikanth.
Yeah.
How do you know that intrahepatic biliary radicals are dilated?
So the
What's the
normal
size?
normal size is 4 mm, sir. If it's greater than
Right.
6 9, we'll tell the
Good,
test.
good.
Followed by the
What?
distended GB1, sir. And we'll look for CBD dilatation. And if we can also look for the pancreas, if any mass arising in the body, it will pick up only whenever there's greater than 4 centimeters of size. Then it will pick up. We can also look for the pancreatic duct. And we can also look for the free fluid, sir, ascitic fluid, if it's present.
No lymph nodes?
Lymph nodes also we can diagnose.
Okay.
What is the double duct sign?
So both common bile duct and pancreatic duct will be dilated, sir.
The importance of that?
When is it
Sir,
seen?
Importance of the double duct sign.
In which condition would you find a double duct sign?
in case of
Where do the two ducts open?
either C head of pancreas, sir.
Oh.
In the ampulla of water, ampulla
Ampulla waiter,
of water.
slit of truct, both the things are going to dilate.
Okay, it is said that in the elderly patient, if there is obstructive jaundice is there, and you find a double duct sign, it is almost 100% diagnostic of periampullary carcinoma head of the pancreas.
Right.
Okay.
Okay.
You need not to do any other investigations to make a diagnosis, but that is almost 100% diagnostic in an elderly male patient presenting with a jaundice.
Okay, sir.
Okay.
Srikanth, what will you test in urine, which will tell you that it's obstructive jaundice?
Sir,
What test do you perform on urine to tell you that it's obstructive jaundice?
sir, in urine, in obstructive jaundice, this conjugated bilirubin will be present, sir. So we can just
Bilirubinemia.
yes.
Urine. Okay, very good.
In
Why should there be
urobilinogen, what will
bilirubin?
happen to the urobilinogen in the urine?
Will you
Sir,
get
it
urobilin?
won't be.
Urobilinogen?
It won't be present, sir. Only conjugated will be. Your conjugated bilirubin only will be seen in this.
Why do you get bilirubin, conjugated bilirubin in urine?
So because of this obstruction at the distal end of the CBD, so the conjugated will be keep on increasing in the blood. So from that it will go to the glomerular filtration. So
Okay, so you've done an ultrasound. Do you have the
Yes,
ultrasound
sir.
report with you?
yes, sir, I have it, sir.
Let's have a look.
Sure.
Okay, LFT is fine.
LFT
Okay,
I'll
just
show.
tell us the important stuff there.
Here, LFT, sir.
No, tell us about the ultrasound. What's so important in ultrasound?
So one thing, intrahepatic biliary radical dilatation and abrupt tapering of distal CBD is noted, sir. Those are the two, and again irregular heterogeneous mass lesion, which is involving the epigastric, involving the pancreatic head and surrounding tissue.
Okay, so what do you think is it indicating?
So this indicates maybe a mass arising from the head of the pancreas.
Have they said anything about the fluid and lymph nodes?
So no, sir, they didn't mention anything about it, sir.
Okay, now next. Okay, you've done this. You've sent the
Yes, sir.
patient to the ward,
Yes, sir.
right? CT will take some time. So what do you do in between? How do you manage the patient till
So,
getting CT?
in between, we need to prepare the patient, like to improve his nutritional status.
Okay, so what do you do that?
Nutritional status, we can
How much is the patient's
improve
albumin? How much is the patient's albumin?
to 3.1. 3.1.
Okay, so you take care of the
So,
nutrition. What else?
yes, sir. Again, we need to improve his hydration.
Okay. Why do you want his hydration to be good?
So to maintain the urine output for the patient, and
so how will you measure? How will you know the patient is hydrated?
so we need to look for the signs of dehydration to prevent it.
Okay.
We
Urine
look at the
output
and also the
hematocrit.
signs of
Urine
and
output and hematocrit are the two ways which you look for hydration.
Yes.
Okay. Then what else?
Done
nutrition, you've done hydration. What else?
So if there's any chance of if there is infection, then we'll start him on antibiotics.
Start him on antibiotics. What else? You said something about PT-INR. So what do you have to give?
We need to correct the prothrombin by we can correct it by giving vitamin K.
So
vitamin K will give, sir.
Don't go around giving me the reason before telling me what you have to give. Say I'll give vitamin K. Then wait,
okay.
We'll ask you why do you have to give.
We give vitamin
the reason and then
to correct the correct the coagulation factors, sir. 2, 7, 9, 10. And
what about itching? What about itching? How will you relieve that?
So we'll give the patient for a urodeoxycholic acid. We'll give which helps in reducing the itching. Along with that, we can also give first line drug cholestyramine.
Cholestyramine.
And also we can also give rifampicin. Also we can give as a second.
Very good.
And again, to make the skin dry, we can give skin emollients. We can give.
You can give even antihistamines.
Antihistamines.
Okay. So you've done this. Now you got a CT done.
Yes.
What did the CT show?
So we didn't do a CT for this patient. So he just got admitted yesterday.
Okay.
We did.
Okay.
MRCP we did. And you just
suppose the CT is equivocal. Nothing. It says whatever is there in the ultrasound. Can we do anything? Or CT says see ahead of pancreas. What do you do now?
Sir, so if I do a CT will see ahead of the pancreas, I need to know whether it's a resectable or a not resectable tumor. So depending on the, and we'll know in the CT this infiltration of the tumor. So the coming to the CT will do a pancreatic protocol CT will do.
Okay, right. So what is pancreatic protocol?
This pancreatic protocol CT is contains of these 3 phases: pre-arterial, arterial, and portal phase.
Some people have 4, but usually 3. Okay. So
arterial venous and portal venous. It's not pre-arterial because that is plain that you will anyway do.
Okay.
Right. Okay. And now you think it's the head of pancreas, it says. Now what will you do?
One question, Shrikant. Your sonologist is telling you to do an MRCP for further evaluation.
Okay, ma'am.
Will you listen to the sonologist or will you not listen to the sonologist?
Accordingly, we should do first MRCP, ma'am. And CECT.
No. Ma'am has asked you, will you do MRCP or ERCP or not? Don't say first I'll do MRCP. You answer the question yes or no. Don't first say I'll go and do MRCP.
Yes, sir. We'll do it, sir, because we did it MRCP answer.
Okay, why will you do it and why will you not do it? Now you come to now you answer ma'am's question.
Ma'am,
what is the advantage of doing it and disadvantage of doing it?
Ma'am, MRCP will give a clear idea about the intrahepatic biliary radicals and common bile duct, pancreatic duct, and the we
So
can
you
know
want to see all that when you want to see the CA head pancreas tumor?
no, ma'am.
Is there any investigation?
What is your answer?
CECT whole abdomen.
Yeah, so your answer is lower end tumor, you will do a CECT.
Yes, ma'am.
If it is an upper end obstruction, you would prefer to do an MRC.
MRCP.
Okay. There is only this much answer. Don't try to do too much justification.
Okay.
Leave something for us to ask. But the patient has some other problem also. He is having thick-walled bladder and cystitis. So by the time you prepare him for pills, he might have some other problems related to the prostate. Would you like to take care of that also?
Yes, ma'am.
Just bringing it to your notice that that also needs to be taken care of. So now you tell us how you will prepare this patient for, as Dr. Sahai said, it is a resectable tumor. Okay. The vessels are not involved. It's a 2.5 centimeter CA head pancreas. What will you do now?
Ma'am, we'll do a midline laparotomy or give a rooftop incision, ma'am. So after opening up, we'll look for we'll just explore the abdomen and
directly. Do you want to confirm your diagnosis or no?
Yes, ma'am. I want to confirm my diagnosis, so I'll do a tissue.
How will you confirm?
It can be done either ultrasound, endoscopic, ultrasound guided biopsy.
Yes. Yeah.
You always need a tissue diagnosis in CA head of pancreas or surgical jaundice.
Sir, according to the literature, there's no need for the tissue biopsy in case
according to literature, according to Benjamin,
there is no.
Just according to you.
There is no need for tissue biopsy for the head of pancreas or periampullary carcinoma.
So, what are the indications for tissue biopsy?
There is no need for tissue biopsy for everybody, or there is no need for tissue biopsy for some category of people or centers.
No idea, ma'am.
Okay, so generally, yes, it is a difficult area to take a biopsy from, and many a times it is not feasible. But if you can get an ultrasonography guided sample, you should try to take it. Okay, if you are in a center where your morbidity and mortality rates of pancreatic duodenectomy are very, very acceptable, which is less than 5% morbidity. Okay, then in those centers, it's justified to go ahead without a tissue biopsy, provided all other information is pointing towards malignancy.
Okay.
You can't need a tissue biopsy. Only you must have a tissue biopsy if you are going to go in for non-surgical management.
Okay, sir.
Right. Otherwise, it may not be. Okay.
Shrikant, can you tell what are the tumors where you do not require a tissue biopsy for going for a radical operation?
Sir, in first is CA head of pancreas periampullary carcinoma, and in case of parotid swellings also there is no need for tissue.
Okay. Yes.
And,
some really important one.
CA gallbladder?
CA gallbladder.
Renal cell carcinoma?
Okay.
Sir is giving all the answers. Shrikant, you should be giving the answers.
I think somebody's TV is
So
on.
essentially, there is a group of tumors where.
Can you please ask somebody the TV is on?
Dr. Patna,
Okay.
It is making a lot of the noise there.
Yeah. So now, give Srikanth. Have you disappeared?
Yeah, it has disappeared now. Yes. Right.
Now, Srikanth.
It is at my end. Sorry about that. Just mute karo.
Srikanth, tell us quickly.
Sir,
4 malignancies where you don't require
sir,
a tissue diagnosis.
renal cell carcinoma.
First, only
parotid
the give me the 4th one. So it's giving you 3.
both one.
Testicular.
Testicular tumors. Okay, sir.
So we get the marks. You don't get any. So
Sorry.
you don't get any.
So these are all tumors where you should not do. Even if it is possible to do, you should not do a tissue biopsy. Ovary is also one of them.
Okay. Okay.
Can the barium studies make a diagnosis of carcinoma pancreas? You know, in our times when we did not have the ultrasound and CT scan, we used to make a diagnosis based on the barium studies.
Yes, sir. We used to have that inverted 3 at the on barium studies.
What is the full name of that inverted 3? Inverted 3 sign of Frostberg.
Frostberg.
Right. And that is for the periampleuric carcinoma, isn't it? And
Yes,
for
sir.
carcinoma head of pancreas, what was the sign?
That is norm 3 sign. It's
No,
reverse
no,
of
no.
3.
No, there is a dilated C loop of the pancreas, C loop of the duodenum is there. What is that called as? PAT sign, you know? PAT sign was it? Inverted,
Bad sign.
the dilated C loop of the duodenum.
No.
Okay.
Another benign condition of pancreas for which barium was useful for planning the management, if you know, before CT.
Chronic pancreatitis.
Not chronic, pseudocyst. We used to check whether it is adherent to the posterior wall of stomach or not, to decide whether gastric jejunostomy will be helpful or something else.
I think we're almost done. Time is over.
Yes, sir. Kanagwal, sir?
Srikanth,
Yes, sir.
one quick question. What is
Yes, sir.
groove pancreatitis?
Yes.
Have you heard of this term, groove pancreatitis?
No, sir.
No?
No.
It is pancreatitis of the head of the pancreas near the duodenum, and it mimics carcinoma head of pancreas. In fact, most patients land up with the Whipple's.
It presents
find out that it's a benign condition.
with outlet
Sir, but-
obstruction as well.
Sir, but it's arising from head only, no, sir. No.
It is called paraduodenal pancreatitis or groove pancreatitis.
No.
Okay, so Dr. Hitesh, let's call
Yes,
it
sir.
off.
Yes, sir. Kanagwal, sir, are you there?
Yes, sir. Yes, sir. Yes, sir. Yes, sir. So should we give Srikanth a chance to ask any doubts or clarification?
Definitely.
Srikanth?
Sir.
Khanna gave most of the answers to him.
Yes, sir.
He's
Yes,
got
sir.
something
I
to
will
answer.
listen today. If you have any doubts, you can clarify with the senior faculty here.
The last one, sir, what sir told, like the group pancreatitis.
Yes,
Go and
yes.
read about it.
You read about that one.
It is usually in alcoholics. If patient reaches the stage of outlet obstruction, usually it is irreversible and may have to do pancreaticoduodenectomy.
Okay, sir.
Right. I like to suggest both the candidates that you think as an examiner. So try to create question in your mind. What questions can be asked?
Okay,
Right.
sir.
And whatever you answer, from that answer, what leads can you get? This is the best hint. I think this is how we never come with a stereotype questions in our mind. So whatever you answer, probably the question links
From
your answers only. If you give wrong answers, you will be tracked to the wrong path. So better to discuss in your daily routine words. You can ask your colleague or you can present to your colleagues. They can ask, you can change the roles. That will be a better exercise, I think. We have...
Best way to prepare is to ask.
Yes, sir?
Discuss between, best way to prepare is discuss between your...
Yes. most of the examiners, they remember only by taking cases only, right? Otherwise, those who are not with academics, they also know the same knowledge, but they are not well versed with the question answers, right? So this is what I suggest you.
Yes, thank you, sir.
Thank you.
Thank you, sir. Thank you very much. Thank you, Aparna ma'am. Thank you for
Thank
staying
you,
with us
Dr.
till late night.
Yeah.
Anna sir, thank you. Rajiv sir, Ritesh sir, and other senior faculty
Thank
who
you.
are here. I also thank both the students, Dr. Rajiv sir, Dr. Asha, and Dr. Shrikant for making this evening. So we look forward for one more event in the next Friday. So any student who are interested in presenting can reach out to me at the number given in the group. So look forward for next Friday's meeting. Thank you very much.
Thank you, sir. Good night.
Thanks.
Thank you, Dr.
Yes,
Panagavel.
thank you, ma'am.
And great
Thank you, ma'am.
activity. Thank you.
Thank you, ma'am. Thank you.